I think I learned this as a resident, I think is really like a very transformative thing, is like, I'm always looking for the things that don't fit. I think cognitively, when you hear a story and there's a couple of details that don't match, there's a cognitive bias to reject the details that don't fit because they're uncomfortable, right? It's like, that doesn't fit with my great idea. But I think, you need to turn into the wave. You need to embrace those.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm Dr. Cyrus asking here with Dr. Nick Mark as per usual. How's it going, Nick?
Good to be here, buddy. Good. Busy week, busy night. Picked up an extra shift last night, and a little sleepy today. That's all right. This always wakes me up.
Doing the Lord's work. That's good.
Yeah, and as you can see, going to a Mariners game this afternoon after we finish recording.
Yeah, no, I'm super excited for you. I'm not going to a Mariners game or any baseball game for that matter. I will be covering the ICU for the next week, but love doing that. It's always fun to work with the residents, and hopefully we'll see something cool. So yeah, nice. Can't complain too much.
Nice, man. Well, enough about us. What are we chatting about today?
I've been wanting to do an episode like this for a while, kind of since we started Critical Care Time. This idea of a Tales in the ICU type episode format. So it's time to, I think, give that episode its time in the limelight here. So I think periodically what my vision is, and listeners, please chime in if you think this is silly. But my idea was periodically, as a different kind of episode format, we could sort of like pitch each other cases that were inspired by things that we saw, sort of give our listeners and ourselves an opportunity to kind of work through a case using some of the lessons maybe that we've learned on other episodes of Critical Care Time, maybe other podcasts, through, of course, your own clinical practice. Really, the idea is going to be to try to explore clinical reasoning in the critically ill. I guess maybe, Nick, you're dressed for it. I know you love baseball. Maybe it's time to go ahead and play ball. All right, Nick. So here's your case. So let's go ahead and say that you are covering nights at a regional referral center, and you get a call from an outlying ED. The patient in question is a 79-year-old lady. She's highly functional, does live in a nursing home, but she's kind of like the head honcho at the nursing home. Everyone loves her.
The queen bee.
The queen bee, exactly right. So unfortunately for this young lady, she was found in bed, had been kind of not really feeling herself, but was found in bed earlier in the day. It seemed to be quite lethargic. So the thought was, okay, maybe she's just not doing so well with this UTI that she had symptoms consistent with. But at the end of the day, they're like, okay, we need to take her to the ER, get her checked out. So she actually shows up in the ER, and she does get a set of vitals there. And kind of interestingly enough, her heart rate's around 40, 45. I think they clocked her at 44. And she's got a blood pressure of 89/47.
I don't like any of those numbers.
Yeah, not so awesome. And what's really funny, actually, is that she's dutifully been taking her blood pressure medication for quite some time. She always gets it at the nursing home, no cessations or anything along those lines. Interestingly enough, she's on atenolol, which, of course, like we could debate the utility of atenolol as a primary blood pressure medication ad nauseum, but it's been working well for her. So we'll just say that, that's what she's been getting. Anywho, so the ER doc gives her a liter of lactated ringers. Blood pressure improves a little bit. She's 98/55 or so, but really that heart rate has not budged an inch. And so, Nick, here we are. I think before getting deeper into the episode, I know that a lot of our listeners have asked about your sort of like talking to the ER about patients, landing patients from the ED, so on and so forth. This came up a lot on our socials. And so, I thought this might be an opportunity for us to explore how you, as a seasoned intensivist, might take this call from the emergency department.
All right, so we'll do a little role play here. Got it.
Yeah, a little role play.
That's the stage our relationship has gotten to. Got it.
That's right.
So okay, so I think I'm listening. Maybe I'm taking notes. I think it's good to sort of make sure I haven't missed anything. So a good summary statement goes a long way. So it sounds like we've got a 79-year-old woman, nursing home resident with a suspected UTI, who is hypotensive and bradycardic. She's on atenolol, but this seems out of proportion to it. She hasn't improved despite some crystalloids. Have I got that right? Sort of a confirmation.
Yeah. Awesome. Perfect.
Another thing that I'm really interested in is like, how does she look? You told me some numbers, you told me a little bit about her, but like, just how does she eyeball? That's something that somebody in the room knows that I don't. Other things that are important, I mean, obviously the rest of her vitals are going to be helpful, her labs are going to be helpful, but sometimes, one of the advantages the ED has is they see a little more context than we do, especially when you have one of these like transfer situations. Sometimes the patient is going to get transferred to the ICU, but the family isn't. So what collateral do they have from them? This is very important. 79-year-old nursing home resident, like, what are her goals of care? What does she want? What does she not want? Is there a pulse with her? Can you give me the phone number of some family members? Stuff like that. Because like, unfortunately, sometimes this information gets lost in the shuffle or kind of oversimplified. So making sure that you get it from the horse's mouth, so to speak, from the ER doc who's in the room with these people, can be very helpful. What else? I mean, I think, data. I mentioned more vitals, more labs. Is there any imaging? I think, one really important concept for learners is this sort of idea of like timing or chronicity. You know, is this like acute, subacute, acute on chronic? Like, how long has this gone over for? This sounds very acute to me. Maybe acute on subacute, like a couple of days, but sort of confirming that's very useful. And then, finally, kind of good thing to ask people is like, what are you thinking? This isn't a challenge like, hey, dummy, like, what do you think this is? This is just like, hey, like, what do you think this is? I
Yeah.
mean, they might have thought of something that you didn't. So always good to ask.
Yeah. I think that's great, Nick. I mean, I think I would echo all that. And the last point is perhaps a bit controversial because, of course, like you don't want someone else necessarily doing your thinking for you, and you also don't want to fall into that trap of like kind of being biased to follow that diagnosis that you've been given.
Premature closure. Yeah. Yeah. You
Yeah, exactly.
avoid.
Yeah, but I often will ask that because I think I try to be mindful of the potential for that premature closure. And then with that in the back of my mind, I do think, especially in a situation like this, you're not the boots on the ground. They are. They're seeing the patient. And I think as long as you ask that question mindfully, I think it can be helpful. So
Yeah. Yeah. I think asking it in a way that isn't like challenging is
yes.
key. But
Yes. Yeah, definitely true.
I guess another thing that, really important lesson that I think, uh, I think I learned this as a resident, I think is really like a very transformative thing is like, I'm always looking for the things that don't fit. I think cognitively, when you hear a story and there's a couple of details that don't match, there's a cognitive bias to reject the details that don't fit because they're uncomfortable, right? It's like, that's doesn't fit with my great idea. But I think, you need to turn into the wave. You need to embrace those. And so I think here the important thing is, why is she so bradycardic? Most people who are septic with a UTI are going to be tachycardic to compensate. Most people who are hypotensive are tachycardic. So something weird is going on here, and we need to sort of embrace that. And maybe the specific questions about that are like, what are you seeing on telemetry? Have you done a 12-lead EKG? Are there other labs we need to think about, like trope? You know, hey, do you have a point of care ultrasound machine in Bumsville emergency department? Whatever.
Yeah, no, that's great. So yeah, uh, I think you really hit the nail on the head, Nick, with that point about the hypotension, the bradycardia. It's kind of like does not compute. Like these are two things that are normally not seen together in a typical ICU patient. To your point, and so my thing is like, okay, well, I could like sort of reject an element of that, which seems a bit silly because this may be the crux of the diagnosis. Or alternatively, maybe you could think of a unifying organ system, disease process syndrome, whatever, that might be able to join all of these things in maybe unholy matrimony. Now, I think it's good on the one hand to be a lumper and not a splitter, but we've said this several times on the show. Hickham's dictum often does rear its ugly head when it comes to ICU patients, i.e., a patient can have as many problems as they damn well please, and maybe there are multiple things.
Darn well, please. This is a family
Sorry.
podcast.
Yes. Sorry. Yes. Yes. We're role playing, but it's a family podcast. Okay. That's also there's also some discordance there, but I'll leave it alone. I think, again, before revealing too much more, Nick, I'd be curious, to hear, let's see, again, focusing on the bradycardia and the hypotension, you know, if there are particular items on your differential, or perhaps like how would you start building a differential for a patient like this? What are you thinking about? I guess just as low hanging fruit as I always reach for, I think about, hey, is this a primary cardiac issue? I'd want to know about like a CAD, ACS type situation.
Yep.
Certainly there's a world in which someone could have acute coronary syndrome affecting conduction pathways, so on and so forth, resultant shock, etc. But yeah, tell me how you would look at this, Nick.
Yeah, so I mean, I think, there are certainly tools that you can use to sort of try to formulate a really comprehensive differential, kind of thinking about every sort of category. Vindicate, vitamin D, I vindicate AIDS. There's like mnemonics for this. The older or more quote more seasoned that I get, the less I tend to use those, and the more it tends to be sort of free form. But I think if you're beginning, it's helpful to have some sort of structure.
Yeah.
I think thinking in terms of organ system is a reasonably good approach. Certainly you mentioned cardiac causes. We got to think about those. you know Obviously this doesn't sound like somebody who's having ACS, but I mean, she's older. She may have comorbidities that make her presentation atypical, and so you certainly want to worry about, like, is this cardiac ischemia, which is, gotten her AV node, for example, and now she's in a heart block. Could she have that for some other reason? Is this just somebody who has like sick sinus syndrome, and the combination of that plus beta blocker is slowing her down? I didn't ask, but does she have a pacemaker? And if she does, is it working? That's certainly a consideration. And then could there be some other cardiac process going on, like some infiltrative process? Does she have amyloid, or, hemochromatosis or something weird? You know, we're probably not going to make that diagnosis on the phone. That'd be pretty baller. But thinking about like rarer things too. Another big sort of category here is maybe endocrine stuff. Does she have hypothyroidism? Does she have adrenal insufficiency? Is there something that could explain this? Other clues I might look for there would be like, what's your temperature? Somebody whose heart rate is slow and they're cold is very suggestive of those to me. And that's going to change our management quite a bit. And that's actually a situation where, we're going to want to make sure we're giving stress dose steroids in the emergency room before we transfer this person, along with antibiotics. Another big box is sort of like metabolic causes, right? Like, she's got a UTI, she's septic, she's hypotensive. Does she have AKI? Is she like anuric? Is her K like 11? I think thinking about like hyperkalemia, very important. I think potentially we could think about some like neurologic causes of bradycardia. It doesn't sound like she's that confused, but occasionally you'll see like an inappropriate bradycardia in that setting, worth thinking about. Um, and then finally, and probably this is maybe where the money's at, is thinking about toxidromes, right? A lot of people are sick because of meds that we gave them. You mentioned atenolol in the presentation. I'm worried about like a beta blocker toxicity. There are some other sort of synergies between beta blockers and other states like BRASH syndrome we could worry about. But there's also other toxicities too. I mean, you kind of need a full med list to really think this over. But like, thinking about like, hey, does she have like 10 clonidine patches on her back because she's forgetting to take them off? Is she taking too much Didge? Is she also on a calcium channel blocker that somebody prescribed and there's something going on there? There's a lot of things to consider. I think starting with a broad differential and crossing things off is a good approach.
Awesome, Nick. I think that's super comprehensive. I think maybe from a neuro standpoint, the only other things I'd add is like if she had like a brainstem stroke or something like that, you can see some funky hemodynamics there with maybe some
Good point.
hypotension and some bradycardia. If you had a history suggestive of trauma, then we're talking potential neurogenic shock
Spinal
type
cord.
picture, spinal cord sort of disease. But to your point, like we're not given any of that, and I'm not hiding that much of the story to where it's like, oh, by the way, she also just had a car accident, which I think is a bit unrealistic. But yeah, great differential, covers a lot of conditions that I think could explain the combination of hypotension and shock slash bradycardia. And I think, again, based on the history, we can certainly eliminate some things pretty quickly, which is helpful. But anyway, I think earlier you were talking about maybe telemetry EKG. So we'll go ahead and tell you that we got an EKG, or the ER got an EKG, and it's demonstrating a junctional escape rhythm. And
Mm,
so that's interesting, right? And so for our audience members who maybe aren't familiar, so a junctional escape rhythm is so called because it originates from the junction between the atria and the ventricles. So that may be the AV node, or oftentimes it's actually the bundle of His. Essentially, what's happening is there's some issue whereby the SA node is not able to communicate effectively with the AV node, and thus is not able to generate the appropriate type of rhythm and rate. And so what you end up with is this junctional rhythm somewhere in the neighborhood of 40 to 60 beats per minute. You'll often see that P waves are absent, or if they're present, they may be inverted, which is indicative of retrograde conduction. So the P waves it's actually traveling the other way. And another thing to note, so you have your ventricular escape rhythm, which is like if all else fails, you got that. Well, that's a slower rate typically, even still, and the QRS is wide. Whereas in a junctional, the QRS is still going to be pretty narrow, assuming there's no underlying bundle branch block. So really, you can kind of think of this as a rescue rhythm that is present because something is amiss above the AV node or above the junction. Nick, any other pitfalls or pearls you might want to chime in with?
no, I agree with all of that. I mean, I think, the heart is a wonderful example of redundancy, right? You have this sort of multiple pacemakers that have sort of a staged point where they kick in. And so, yeah, when you see an AV nodal rhythm, an AV nodal escape rhythm, it suggests there's an SA nodal problem or an infranodal problem. So, yeah, totally agree with that.
Perfect. Yeah, no, absolutely good. So, okay.
The next question is why?
Yes. Why? Okay. So as we're sort of like unraveling a little bit more, you ask some questions. So it sounds like the patient actually does have an AKI, and
Mm,
she's got this serum creatinine at 2.2. Her baseline's, maybe zero point 0.7 to zero point 0.9. And also on the renal panel, she's got a potassium of 6.6, which is not typical for her. So
yeah.
now,
So
if
so
we take
that's AB normal, as they say.
AB
All
normal,
right.
AB normal, and yeah. So take a step back, just kind of take it stock. We've got this EKG that's kind of wonky, the vitals that I discussed, the serum creatinine's up, potassium's up, so on and so forth. What do you think, Nick? Can we reshuffle things on the differential?
Yeah, so I think, some of the things that we were initially thinking about, like MI, cardiac ischemia, probably go down the list a little bit. Some of the endocrinopathies probably go down. I'm less worried about like cardiac sarcoid at this point. The things that go up the differential are more like toxic stuff. We mentioned BRASH syndrome before. This is very much fitting with BRASH. I think we can define what that is in just a second. But I mean, I think that the key sort of takeaway here is that like that's high, but that's maybe not high enough to explain this all by itself,
Great
right?
point.
Like hyperkalemia can cause you to have like an abnormal rhythm, absolutely. But 6.6 is probably not high enough to explain this. And a creatinine of 2.2 is high, but it's not like 7, right? It's not like the person where I would expect to see like cardiac arrhythmia as the primary issue. So I think this is sort of coalescing a little bit into a cohesive story. One other sort of random fact that may be germane here is I think you mentioned the patient was on atenolol. Atenolol has the distinction of being a beta blocker that is primarily renally excreted. So, you could imagine that this person developed AKI and then they were dutifully taking their beta blocker and it was accumulating
Yeah.
and just slowly poisoning their SA and AV nodes.
Yeah. Well, great points. And yeah, I didn't tell you this, but also to sort of support the idea that the heart, so to speak, is not the primary culprit here. She did have an echo that she dug up from 9 months ago. She had grade 1 diastolic dysfunction, mild aortic stenosis, mild concentric hypertrophy, consistent with this history of longstanding hypertension. But really nothing too crazy there. And one other thing I'll comment on, Nick, before I ask you to sort of like put your chips down, would be the way in which you did that. I think is really important for our listeners to appreciate. You sort of like you have this like illness script that fits a disease process you have in your mind. You're trying to sort of flesh it out. or alternatively stated, you've got like a painting that you're trying to work on, and you start with your sketch or your sort of like blueprint for the work of art, and you're like adding layer after layer as you're getting more and more information. You're kind of like building complexity in a coherent way. And so I think that's really good because
Hopefully a coherent way. Sometimes you're like doing that like Jesus mural meme,
oh yeah,
that
yeah, right, yeah,
sometimes that's the painting you're making.
right, or you end up with that like some facsimile of that Cristiano Ronaldo sculpture, that like uh much maligned sculpture of him. But yeah, in this case, I think you did a great job of kind of adding the layers and working towards the differential, which is something I hope our listeners will aspire to. So okay, what do you think's going on?
I should say one other thing too, which is that like, even though I feel like we're sort of like coalescing on a diagnosis, I'm still going to test a bunch of that stuff. Like I'm still going to send a troponin. I'm still going to send a random cortisol. I'm still going to check a TSH, the reflex T4. Like, some of those things are like, like they cost like pennies to test and they would be disastrous to miss. So we should still do them. Similarly, like I'm going to throw a probe on when I meet this lady, and I want to make sure she doesn't have any regional wall motion abnormalities that might fit with like an inferior wall MI, for example. Like just because things have gone up or down the differential doesn't mean they've gone off the differential. So we want to make sure we're still entertaining them.
Yeah, it's like this idea of like Bayesian reasoning. It's like things are kind of moving up and down. You're sort of narrowing in, but I think it's important. Like the reason we do what we do is we don't just throw the blinders on immediately and focus on a diagnosis.
Now, one sort of little pet peeve I'll share, sometimes working with residents, you see this, where there's like a great admit note where you've got this wonderful differential on day 1, and it's like, oh, really thoughtful. And then on like hospital day 5, the note still has this amazing differential. Right. And it's like, no, there's no differential. Like we solved it. It's not these other 7 things. So get those out of there. Yeah. So, I mean, while I think it's really important to like entertain, a lot of possibilities and be thoughtful and Bayesian about them, like once they're gone, they're gone. Like stop copying that forward in your note.
Yeah. Now it's just become note bloat. And it's not,
it's like you're showing me how smart somebody else was. Like, nice work.
Yeah. Okay. So push your chips in, Nick. What do you think's going on?
This sounds like BRASH syndrome to me, my friend.
Beautiful. Very good, Dr. Mark. So you listened. And yeah, so, I think, if the patient were on other cardiac medications or wasn't on anything and just had like very severe hyperkalemia, might be different. But yeah, this was a case of BRASH syndrome, inspired by 2 cases I actually saw recently in the last, several months or so. And so now I think that we've worked through that. We can take this opportunity to jump into the disease itself and how we might treat it. As Nick astutely surmised, this is a case of BRASH. And, I think, as we often do on Critical Care Time, we should maybe delve into the pathophysiology. So if you guys will bear with me, Nick,
before we do, we should probably delve into the acronym, right? Like,
sure,
what is BRASH? What does it stand for?
Actually, why don't you remind me, Nick, what is BRASH?
So B is bradycardia, R is renal failure, A is AV nodal blocker, S is shock, and H is hyperkalemia. Perfect. And so this patient has got 5-4-5. She's bradycardic. She's got creatinine of 2.2, presumably renal failure. She's on an AV nodal blocker, atenolol. She sounds like she is in shock, and she's got hyperkalemia. So the shoe fits.
She's perhaps batting 1,000, as you might say in your current garb.
Yes, indeed.
So okay. So how does this UTI that she presumably had several days ago result in BRASH? Well, it's really, I think in this case, more about how the urinary tract infection and generally just illness could potentially precipitate an AKI. Someone's maybe not feeling great, not drinking as much. They end up with this pre-renal azotemia, which manifests as an AKI. And then that AKI can certainly lead to hyperkalemia. And so in broad strokes, what we see with the BRASH syndrome is the hyperkalemia essentially potentiates the effect of the AV nodal blocking agent. And that's what results in the shock and bradycardia that we see in BRASH syndrome. I'm going to get into some more details here in a minute, but Nick, before I do, anything else you'd add to that introductory stuff?
No, I think that's a great summary of what we're dealing with here.
Perfect.
I think it's really important to understand how, like many things in medicine, there's sort of a pathological spiral here, which I'm sure you'll get to.
Yeah, absolutely. So there's definitely a spiral, and then I think an important concept here with BRASH is it's not just the sum of its parts. It really is like the whole is greater than the sum of its parts. It's a synergistic interaction that results in, as you said, a spiral, the self-perpetuating spiral of bradycardia and shock. And really, I think the trick for me anyway is you'll see this bradycardia is really out of proportion to either the potassium level or the beta blocker dose alone. And I think this case does a really good job of illustrating that. So to sort of work through some of the elements of the cycle, a lot of times you're going to have baseline risk factors. So you might have a patient who is elderly, maybe they have chronic kidney disease, and they have, for whatever reason, some volume depletion. In this case, it's a elderly patient, urinary tract infection, not doing so well, not feeling so well, I should say, and maybe not eating and drinking as much as they normally do.
And worth remembering that older people tend to have lower total body water and may have less access to water. So those are other
Yes.
important risk factors.
Perfect. Yes. And then other element here as a baseline risk factor would, of course, be the AV nodal blocker. So that could be beta blocker, a non-dihydropyridine calcium channel blocker, or something like digoxin. As I sort of alluded to.
Or multiple of them. And that's actually a very
Yes.
common feature of this condition too, which is that somebody is on 2 or 3 of these meds that work synergistically.
Yes, absolutely. So let's say I could easily imagine someone who is on, a beta blocker and digoxin, for their atrial fibrillation, which has been hard to manage, and their blood pressure. And so, yeah, to your point, totally could have multiple risk factors, multiple even medication risk factors. And so, whatever the case is, you're typically still going to need to have an initial trigger, and it's often going to be some combination of, poor oral intake, infection, some sort of nephrotoxic insult, whatever it is, or whatever combination thereof, you end up with an AKI. And so that AKI, we know that patients with an AKI often have impaired potassium excretion, and so their serum potassium starts to rise. And also, a lot of these folks may be on RAS inhibitors or potassium-sparing diuretics, which also can further potentiate the problem, further add fuel to the fire. And so here's when we get a little bit into the nitty gritty. So
the molecular weeds. Yeah. Love it.
yes, that combination of hyperkalemia and AV nodal blockade really can result in profound bradycardia. Hyperkalemia in and of itself, especially severe, like greater than 7 hyperkalemia, can impair resting membrane potential in cardiac myocytes, making it essentially more positive, thereby slowing conduction. So that's really what's happening. And so on an even lower or on an even more granular level, what's happening is you have those fast voltage gated sodium channels, which are responsible for depolarization in the atrium of the ventricular myocytes. These channels require a sufficiently negative resting membrane potential in order to reset between action potentials. When the resting membrane potential is less negative, i.e. more positive, in hyperkalemia being a situation where that can happen, you end up with more sodium channels in the inactive state, less inward sodium current, resulting in slowed conduction. On top of all of that, we've got an AV nodal blocker on board. You're going to suppress SA/AV nodal activity. And so that kind of communication between the SA and the AV node is going to be impaired. Generally speaking, you're doing it on purpose, but together that hyperkalemia, that AV nodal suppression, it is sort of this synergistic problem that can result in junctional bradycardia or a high-grade block. How do you get the shock?
And by the way, for people for whom phases of the cardiac action potential are not like ringing a clear bell, I will definitely draw some pictures of this on our website. So go to the show notes. You can see what phase 0, phase 1, et cetera, and all the drugs and what they all do. That quick review there.
Excellent. No, thank you, Nick. Yeah, because my drawings would just look like stick figures that were very sad. I guess drawing a sad stick figure might be an accomplishment. But anyway, I digress. It's just okay. Well, we're not all as gifted as you, Mr. ICU one pager. Okay. So how do you get the shock? Well, that's not terribly hard to wrap your head around, because that bradycardia is going to reduce cardiac output. We know that heart rate times stroke volume is essentially your cardiac output. So you can only augment your stroke volume so much, and especially in the setting of volume depletion, you may have a hard time doing that. So again, you end up with this hypotension versus shock state. And then as that continues, that low cardiac output is going to lead to worsening renal function. So, if that MAP drops, we know that your renal perfusion pressures or your MAP minus your CVP. And so as that MAP drops, renal perfusion worsens, and then renal function continues to decline. That results in less potassium excretion, further increase in serum potassium, and
And less drug excretion too.
less drug excretion. You're right. And really, this like loop continues. So basically, worsening bradycardia, lower perfusion, worsening AKI, higher potassium, all fueled by this ongoing AV nodal blockade. That, my friends, is the BRASH spiral.
Excellent. Beautiful, beautiful picture you painted for us there. That did not
Tried to.
look at all like that Jesus mural.
No, thank you. I appreciate it. And then last point I'll make before, Nick, I ask you to teach us how the heck we treat this thing is really just like hammering home the severity of the bradycardia. So I think, Nick, you had mentioned this, like neither of these things that we talked about, these elements, should cause that degree of bradycardia. Really, like you typically think of bradycardia in the setting of hyperkalemia alone as being like a potassium of greater than 7 or so. But again, it's when you have that combination of hyperkalemia and the AV nodal blocking agent, that's when you really see this profound bradycardia. And you've got the beta blocker effect that's kind of continuing to linger, inhibiting sympathetic tone, impairing renin release. So it really is a horrible synergy. And last thing I'll kind of say is really just think of bradycardia out of proportion to potassium and BRASH syndrome. I think that in the right patient, if you see that, definitely should be a clanging association that you keep in your back pocket.
Yeah, love it. And also big plug for having clinical pharmacists on your team who are really good at spotting, the symptoms that match with meds, because that's the other sort of pattern recognition aspect of this disease.
Excellent. All right, Nick, why don't you take us now into fundamentals of treatment? What do we do for a patient like this?
Okay, so basic stuff: airway, breathing, circulation. Is she oxygenating okay? Is she protecting her airway? Is she so hypotensive? We need to think about boluses and pressors and stuff like that right off the bat. There's a place for disease specific therapies, but there's also a place for just like resuscitating sick people first. Might be reasonable to put this lady on telemetry. Actually, yes, obviously we're going to do that. Getting good access. Maybe she needs a Foley. Thinking about like, is there an obstructive component too? Will that help? All that's important. We're going to send labs. We're going to do probably a point of care blood gas, see what her electrolytes are, point of care, all that stuff. One important thing to remember is that when you admit somebody from the ED, you know what their status was. And when they get to the ICU, you want to see what their status is. So, if her K was 6.6 before and now it's 8.6, that's going to change things quite a bit. So let's get all that stuff cooking. Now we can get into some of the other sort of therapies. By the way, I think we're going to just empirically cover her for sepsis, because even though we think this is all BRASH, she had this UTI, maybe she's failing therapy. We'll just broaden that empirically. Why not? Okay, now that we've done all that basic stuff, let's talk about like disease specific management. So I think there's like maybe a little controversy about the role of calcium in hyperkalemia in general, but I want to emphasize that in this case, calcium is probably your friend.
Mm-hmm.
Calcium is going to stabilize the cardiac action potential. Actually, probably really more what it's going to do is it's going to improve conduction through L-type calcium channels, which should improve conduction, maybe improve rate.
Yeah, and briefly, I'll say that this has been covered a couple times on some other podcasts, and a buddy of mine sent me the article. But the whole like stabilizing the myocardium seems to be a bit of a misnomer, if not completely kind of on its way out. Yeah, and definitely it does seem to be all kind of like preferentially shifting conduction back through these L-type calcium channels. So in the show notes, if Dr. Mark will be so kind, I'll include some data to that effect.
Cool. So watch out for that link. Other things we should do. Let's think about what we can do to manage that hyperkalemia. Potentially, that might mean shifting it intracellularly. So insulin plus dextrose, maybe some albuterol. If her pH is low, maybe some bicarb. Those are all reasonable things to think about. We should also think about actually not just shifting it, but getting rid of it. She seems like, she may not be volume up. If she was, furosemide, a loop diuretic would be a reasonable choice. I think, thinking about like some sort of potassium binder, like sodium zirconium cyclocyclate, whatever. No brand names here. Obviously, we need to hold her atenolol,
Right.
pour form to fix everything, and continue giving somebody poison. If she's on any other meds that could be conspiring with it, like a calcium channel blocker, Dig, etc., we should stop those. And then, depending on how she responds, this is a situation where we might want to think about dialysis.
Mm.
Dialysis will both potentially manage, acidosis. It will potentially manage hyperkalemia. And atenolol is quite dialyzable. So I mean, that is sort of like we're not going to start with that, but knowing that that is a possibility is important.
Nick, those are all great points. And I definitely, if there's more farm stuff, I'd love to hear it. But I also want to make sure that you kind of tell me what we're going to do with that bradycardia specifically.
Absolutely. So I mean, this is somebody where, especially you mentioned they're coming from another facility. So this is probably somebody where you want them to have pads on when they're transported in case they need transcutaneous pacing en route. This is somebody where, they could go from being kind of bradycardic to like very bradycardic relatively quickly. So you want to be alert for that. You should know that atropine is often not terribly effective in BRASH. So, this idea that like, oh, we'll just push atropine, it may not really work.
Right.
You could consider other therapies like glucagon or insulin for the beta blocker toxicity. I think probably the thing that I would do instead of that, or it first, would be just to think about how I could raise her heart rate. So how can I
Mm-hmm.
step on the gas? And so things that I would go for, depending on her blood pressure, which is low, you could use kind of like an inopressor, like epinephrine would be a good choice. You could use dopamine if that's your thing, if you're like 1,000 years old. Angry letters directed to Cyrus at Critical Care Time, as
Hey, no, no,
always.
hold on, no. So, one thing I will say is the to defend myself before I get all the angry letters. I agree, dopamine is like rarely my go-to, but I've had cases
This is the time.
where their blood pressure actually like responds pretty well to crystalloids, but their heart rate is still trash. And so that's my move. Or situations where like I'll try epi first, and they're just so sensitive to the blood pressure effects that I kind of like have to go
Yeah.
with the dopamine or something. But yeah,
Yeah, dopamine is dopamine's jam right here. I'm making fun of it because it's an
yeah,
older drug, but this would be a totally reasonable place to use dopamine. I have used dopamine in cases like this. It's fine.
love
The
it.
other drug that you could reach for in this case, this patient has a bradycardia and a hypotension. If they just had a bradycardia, you might lean more on something like isoproterenol or dobutamine. Those would be reasonable choices as well. The other thing that I'll say is usually these patients respond to treating the metabolic derangements and some inotropes / pressors, but occasionally you do need to put transcutaneous or transvenous pacing in. And so getting ready to do those. And, what that means for me is like, TC pads on the patient, maybe have the TC kit ready, outside the room or in the room or whatever. If they're really sick, you could put that in. Usually it's not necessary, but in some cases it is.
Let me ask you a question, Nick, because this comes up not infrequently. Tell me a little bit about your approach to transcutaneous pacing. Is that something you do for long periods of time? Is that something like, I often worry about the patient's comfort, and getting like little shocks every, second is probably, or not so little shocks is not
Yeah.
great. How do you kind of parse that out?
So in general, I think about TC pacing as a bridge to TV pacing. It's
Love it.
not
Yep.
really a destination. It's something you're going to do because you can just flip a switch. You may, in somebody who is spontaneously breathing and spontaneously moving, you may have a really hard time getting consistent capture, as they breathe in and out, and they're often like, whoa, what's going on? Take a deep breath. The impedance of their chest is going to change, and you may need more energy to go through more lung, more air. So it's not a super reliable way. I think about TC pacing as a really good option in somebody who's like intubated, who's received neuromuscular blockers while I'm putting in the
Yeah.
TV pacer. I don't think about it as a great option in other settings, but it's better than nothing.
Sure. Yeah. The times that I've done it, in someone who's awake, but I'm like, gearing up for, transvenous pacer or something like that. It's like kind of little doses of midazolam or ketamine, maybe
Yep.
some fentanyl, sort of like flirting with that idea of conscious sedation,
Yep.
ready to, like, if I overdo it, of course, ready to take the airway or whatever I have to do. But I've found that if you're not fairly generous with the analgesia and the sedation, not only is it like really not patient centered at all and kind of like torture, but you run into those exact problems, Nick, that you
Your
described.
Press Ganey scores are going to be super low if you do this
Yeah,
to people.
that's right. That's right. But sorry, continue. You're talking about kind of like the process, the transvenous pacing, and
Yeah, I mean, I think that, in general, these patients, if they require transvenous pacing, don't require it for that long. It's typically
right.
just for like a day or two, and then they clear the meds and then they're fine. But some of them do require it. I mean, I've done it a couple of times now for BRASH syndrome. Like it's, if you're comfortable putting in pacers, it's not a big deal to do this. I did one last week, actually, not for BRASH, but for somebody who needed a transvenous pacer. And the guy was like joking with me because I was doing it with somebody else and I was walking them through how to do the procedure. And he was like, okay, now I know how to do the procedure. He was like along for the ride. So, it's
Yeah.
from a patient's perspective, this is a way more comfortable thing. You just get a little bit of analgesia in your neck and then you feel much better.
Right. And so you're just as kind of again a little bit of myth busting. These folks don't need to go to a cath lab to have their transvenous pacer placed, assuming you're going from the neck.
Well, I guess it depends on kind of what your comfort level is too. I mean, so not everybody is comfortable putting in transvenous pacers, but if you are, this is usually something that you can do. Sometimes there's anatomical issues that make it hard to pass it, like if they have like tricuspid stenosis or something like, it may be difficult to put a transvenous pacer in at bedside, depending on what resources you have. Maybe without fluoro, it might be more challenging. So it depends.
Right.
If you've got like a really responsive cath lab that wants to do this, I would never say no to that. Sure.
Yeah.
But, in general, this is something that as a ER doc or as an intensivist, like you can do this procedure,
Awesome.
assuming you've
Cool.
been trained.
Very cool. Very cool. Yeah. So I think we've talked about a lot of the treatment pearls. I think Nick, you even touched on some of like the rationale, maybe some risks, benefits of treatments that we discussed. I mean, any other sort of like take home points regarding treatment before we talk about maybe discharge planning and long term considerations?
I think we've sort of hit on all the key elements. There's sort of the immediate things you're going to do to stabilize heart rate. There's the things you're going to do to deal with hyperkalemia and acidosis. There's the things that you may need to do if that's not enough, like pacing. And then there's the kind of things that like hopefully prevent this from happening again. So this
Mm,
person's 79. Does she really need to be on this dose of atenolol? Can it be lowered, etc.?
beautiful.
Often these patients are on multiple different meds and maybe they don't need that. Maybe they just need one. Maybe just the beta blocker, lose the calcium channel blocker, etc. So I think, this is something where you really don't want somebody to be a repeat admission for BRASH.
Yeah.
So, like when you get them better in the ICU, try to figure out how to prevent this from happening again the next time they get a UTI.
Yeah, Nick, I think you're totally right. Like, this isn't a condition where you really want to see like a repeat admission. There's really no reason for it. And I think, you that dovetails nicely with this idea of like, how do you prepare for discharge? What are your long-term kind of like plans for a patient like this? And when I think through this, I'm like, okay, well, absolutely. Do they need to be on that beta blocker? Do they need to be on as much of it? Are there other sort of medication reconciliation decisions you can make? Do they need to be on the potassium sparing diuretic? The ACE, the ARB, whatever. I think from a renal standpoint, if this person has underlying CKD, you do want to make sure that they are followed for that. Make sure that their renal function does return to baseline. And other thing too to think about is just educating the patient on like, hey, you're maybe you can't come off these medications for whatever reason, and so it is really important, even if you're feeling under the weather, to try to keep up with your hydration and seek medical attention kind of early and often if this is something that is potentially going to rear its head again.
One actually minor point, but potentially impactful point I'll make here is, we're gonna talk at a later date about saving the right IJ for certain lines. This is actually the rare situation where I think that makes sense. You actually do want to save the right IJ for your transvenous pacer in this case. So if this person is sick enough that they need dialysis, I might actually put that catheter on the left in this case.
Nice. Okay, cool.
Just because, if I do have to float a pacer, it's much, much easier to do it from the right IJ than from the left.
I love that. That's a great point. Cool. So, okay. So getting back to kind of like the long-term stuff here. So I think, on the outpatient side, outpatient electrolyte monitoring after discharge, not a bad idea, especially, checking up on that serum potassium. And then kind of mentioned some of this already, but the idea of education, and this may be both for the patient, but also if they're at a nursing facility, making sure that the nursing facility is aware that this happened and that maybe if they're sick in the future, might be a good idea to hold some of these medications like the atenolol or at least dose adjust it, keep an eye on signs of bradycardia, keep an eye on signs of maybe impending AKI. And then of course, like this is probably, I think the ICU admission is always a good opportunity to do this in a lot of our patients is like, what are our goals of care? In a patient like this, who was like super functional in this nursing home, goals of care may not change at all. And so you're going to continue to do all the same aggressive things. But maybe if this is the patient's third or fourth hospitalization in 5 or 6 months for various things, maybe less is more in someone like this.
Yeah. What are her goals exactly? Sounds like in this case though, we've fixed her and the queen bee is going to go back to the sniff where she lives.
Amen. All right, guys. So for the first time in a long time, we've kept our episode under an hour, which is exciting, I think. Hopefully you guys have enjoyed our discussion of BRASH and sort of like this different spin on an episode, sort of like exploring the case in a more organic way. As usual, we're going to have show notes posted to the website. We've already kind of tipped our hand as far as what we might include in those show notes. If you forgot, those can be found at www.criticalcaretime.com. And of course, if you're there, go ahead and subscribe to our mailing list or leave us a comment.
Yeah, we appreciate that. We actually appreciate all you do for us as listeners. Those of you who have left us a 5-star review on whichever podcast platform, we love that. Those who, leave comments or whatever on YouTube to boost engagement, give us a like, subscribe. All of those things really help. You can also help us by sharing the show with somebody, like telling somebody at work, hey, there's this great show. You should listen to it. Here's an episode. Send the link. All of that just helps us grow and get more engagement, which is what we like.
Beautiful. And if you, again, haven't left feedback, please feel free to do that either on your favorite podcast app, through the website, or let us know directly. We do love to hear from you guys. So you can, use X, for example, to get us on
Twitter.
Twitter.
No, it's always Twitter.
It's always Twitter. We are at Crit Care Time there, or you can reach out to Nick. He's at Nick M. Mark. I am at Askins_Razor, and also happy to hear from you. And really and truly, you can really
remember hate mail at Askins_Razor.
Yes, yeah, absolutely. As I was saying before, I was so rudely interrupted. Any permutation of Critical Care Time, you can kind of find us, whether it be Blue Sky or Threads or Instagram, and of course YouTube as well.
I'd like to say big thanks to our podcast team that makes this possible. Folks over at Podpaste who edit, Kurt Belknap who composed the theme music that you're listening to now. Couldn't do it without you. It takes a village. We appreciate you all.
And finally, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening, guys. I'm Dr. Cyrus Askin. So long.
And I'm Dr. Nick Mark. See you next time.